I'm Peter Block here in Chicago at ACC.16 for On the Scene. And with me is Neha Pagidipati, who is, well, she went to Harvard Medical School and then she went to the Brigham, but I'll forgive her that. But the bottom line is she's now at Duke. And Neha has been interested in trying to figure out differences in how stress testing should be done between men and women. So Neha, let me ask you first off the name of your trial and what you studied.
Sure. So we looked at sex differences in non-invasive testing results and prognostic value in the PROMISE trial. And we used the PROMISE study to look specifically at the likelihood of a positive test result between CT angiography and stress testing in women and men, and the subsequent prognostic value of those tests.
Okay, so you're trying to figure out whether or not men do well on one versus women versus the opposite. Sure. What'd you find?
Well, in some we found that the interactions between whether you're a man or a woman, what type of test you have, your results and your outcomes is really complex and interrelated. It does seem, though, that in women, a CTA is less likely to be positive, but probably has better prognostic value than a stress test. And in men, a stress test is less likely to be positive. And while there's a trend towards better predictive value, the difference between CTA and stress testing in men was non-significant.
Okay, so let me ask you sort of a funny question. Why would a CTA in a woman not be as good as in a man?
It's better, probably.
I'm sorry, better.
Mm-hmm. That's an excellent question. It may have to do with the known diagnostic performances of stress testing. So we know that there is a high false positive rate of stress testing in women, and that's what we found. What we found here was that there was an excess rate of positive stress tests in women. A lot of women who had a positive stress test went on to not have a clinical event. So that may have something to do with the high rate of false positives in stress testing in women, and may have something to do with microvascular dysfunction, which we know is more prevalent in women than in men, and may show up in stress testing, but not in CTA.
Yeah, because CTA doesn't really look at the microvasculature, does it?
That's right. It looks at the major epicardial coronary vessels, and it looks for, really is looking for obstructive coronary artery disease.
Okay, so Neha, going forward, give me the short version of sort of the nuts and bolts of clinical medicine related to your trial. I know it's difficult, and I'm not putting you on the carpet here, but if you were to summarize this for the clinicians out there who are trying to figure out what to do with their women patients versus men, what would you say?
It's an excellent question. I think that whether your patient is a woman or a man matters and will probably affect the testing choice that you make. I do think that there is a difference. CTA may be better for women, but at this point, without prospective data, I wouldn't change my clinical practice. It really needs to be prospectively tested.
Okay, so there you have the answer. No real answer yet. We may need a clinical trial to do it.
Yes.
But we're working on it, and in fact, there seem to be some signals, don't there?
Yes, absolutely.
Thank you, Neha, for being here.
Thank you so much for having me.